Awesome. Hi, everybody. Since we are at the top of the hour, we're going to go ahead and get started. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am so honored and excited to have Michelle with us this evening as she presents her presentation, Same Muscles, Different Functions, Synergistic Voice and Swallowing. A couple of housekeeping items before we get started. This webinar is eligible for 0.1 ASHA CEUs or 1 PDH. If you would like ASHA CEUs for attending the session, we ask that you stay for the entire 60 minutes and that you fill out a brief survey. The survey link will be put into the chat a couple of times, and then it will also be sent out via Zoom email twice after the session concludes. So we ask that you complete it within 7 days. And then if you'd like a certificate of completion, just send us an email at tims-unum@tims.com, and I'll put that in the chat as well, and it will also be sent out via email. And then finally, this webinar is being recorded, and the recording will be up on our website no later than 48 hours from this evening. So with that, I'll hand it over to Michelle.
Hi, everyone. Let me share my slides with you so we can get started and get that. Okay. And there we go. Hi, everyone. I'm Michelle Adessa, and I'm a speech pathologist at the Cleveland Clinic's Voice Center. And I'm also a clinical senior instructor at Cleveland Clinic Lerner College of Medicine, where I teach video stroboscopy, perceptual voice assessment, and fees to our residents and fellows. So I receive a salary from the Cleveland Clinic Foundation, but otherwise I have no financial disclosures.
Michelle, real quick, we can't see your slides.
Oh, that's not good. Oh,
I'm
that's
sorry. Sorry to
sorry
interrupt
to
you, but
start
that's
that
why I didn't put Daisy
again.
on.
No, that's okay. Let's see. We tried this. What about that? Can you see it now? Whoop.
Not yet. Should
Hmm.
be right at the bottom of the screen there.
Share. Oh, there we
There
go.
you go.
There we go. I thought I clicked it. Okay.
Perfect.
So now you can see my slides and see what I just said. And we now recently just changed our name from the Head and Neck Institute to the Head and Neck Department. So there's a little discrepancy there, but we are now part of the Integrated Surgical Institute, and I work at Cleveland Clinic. So, all right, let's make sure I can change the slides there. Okay, can you still see my slides? Okay, I think we're good. Like I said, salary from Cleveland Clinic. So let's talk about our learning objectives. Today we're going to be reviewing hyolaryngeal biomechanics. We're going to get nitty-gritty into the musculature and talk about some movements of the larynx and the whole vocal tract in relation to both voice and swallowing. We're going to identify how groups work in both voice and swallowing and how they work across systems. And then we're going to talk about tools to practically treat disorders that are functional in nature. I wanted to kind of narrow this down to how to apply this framework to the functional disorders that we see and work with every day. 5 minutes to talk about just getting to know each other, 10 minutes to review hyolaryngeal biomechanics, 20 minutes to talk about how we can apply this framework across systems so that we can treat synergistically voice and swallowing disorders. And we're going to talk a lot about why that's important. Putting it all together with a case study, and then we'll have some time for questions and discussion. So the origin story for my interest in this particular topic actually goes back to many years ago when I was not a speech pathologist, but I was a singer, classical singer. And I had a colleague who would always talk about, why does it hurt to swallow after I sing? And at the time, I really couldn't answer that question. Um, I remember her always like going like this and being like, oh, I just can't. It just feels really weird to swallow. So I always had that in the back of my mind as I started my training. And I think I've started to understand why that is. So let's talk about hyolaryngeal biomechanics for swallowing. And I know this is very simple in a review for many people, but we always talk about our stages. We have our oral prep phase, our oral transit phase, and today we're going to be mostly focusing on the pharyngeal phase of the swallow and then the esophageal phase. So when we describe this to patients, I think how I tend to describe it is, your base of your base of the tongue moves back, your base of the tongue to the posterior pharyngeal wall, your larynx lifts up and forward, the epiglottic retroflexion happens and covers your airway, and we cover our airway to keep it safe. And then our throat squeezes. And I'm going to be talking a lot about the difference between the open and the closed pharynx today. And so that movement, that upward and forward movement of the larynx is going to open the cricopharyngeus. So this is how we talk about it every day with our patients. And when we think about from a mechanism perspective, from a biomechanical mechanism perspective, we have many, many muscles that play into the hyolaryngeal elevation. And so we're going to get specific about that. We have the mylohyoid, the geniohyoid, the stylohyoid, the anterior belly digastric, and the posterior belly digastric, as well as the thyrohyoid. And those are all in the orange on the slide. And then we also have this concept of this two slings. So there's other muscles in this posterior area, these long pharyngeal muscles that are also helping to lift the hyolaryngeal complex. And those are the stylopharyngeus, the palatopharyngeus, and the salpingopharyngeus. So this whole group of muscles is working together to make that hyolaryngeal complex lift up and forward. This protects the airway and relaxes the upper esophageal sphincter. And we talk about this all day long, and we look using objective measures, especially the MBS-IMP. This is, I kind of blacked out here or read it out, excuse me, where, we would rate the pharyngeal phase. We'd look at the pharyngeal stripping wave. And then on fees, we would look for whiteout. So for effective swallowing, we need to have a closed pharynx. We need to have the bolus be pushed down into the esophagus through this mechanical lifting of the hyolaryngeal complex. Now, for voice, it's a little bit of a different story. So we're going to touch on a couple of systems of voice production. We have a sound source at the level of the glottis with the vocal folds. The larynx, the vocal cords come together, the phonatory subsystem of the vocal subsystems. And we have the laryngeal adductors here in the yellow orange stars, and then we only have one muscle that opens it. So we have a lot of muscles that close, super important for airway protection, but also as we get to talk about the dysfunction of this, that if the vocal cords, pardon me, do not close all the way and muscles are overactive, we start to have a problem. So next, we have the resonating tract. Now, for voice, the space inside the pharynx and the mouth and the nose is what is going to be shaping the sound. So, when we're thinking about what makes a voice sound good, it's really how we filter that sound that is being produced from the larynx. So the resonation component of the vocal subsystems is critical and is extremely variable in terms of how we shape that sound. So the pharynx shapes the sound, the oral cavity shapes the sound, the nasal cavity shapes the sound. Now, effective voicing, therefore, is dependent on the pharynx not being closed like it is in swallowing, but open. And so depending on what you need to do in order to speak or sing, that space may change and that tube size is adjustable. So when I describe this to patients, I describe this as you have a series of hanging baskets. And I don't know if anybody had these in their grandma's house. I had a grandma who had one of these in their kitchen. And so with the top basket being the tongue, the middle basket being the hyoid bone, and the lower basket being the thyroid cartilage and the larynx. This basket at the top is going to affect the basket on the bottom. Because what you do to one part of the system, it will downstream affect the others. So the system is the same, but the muscles function very differently for each task, breathing, voicing, and swallowing. And I will say the disclaimer for this is that I'm not really touching on the breathing dysfunctions that may happen in the upper airway today. It's not, it should have been same, same muscles, different function, and all of these three things. But I think if we can think of the system rather than the dysfunction, and then we can work from a framework to understand which thing can be impaired and how they can help how we can use the tools from one thing to help remedying the other problems that may exist. So there may be co-occurring problems that if we don't look at the whole system from a biomechanical perspective, we can't always solve, especially with functional disorders. So we want to reframe this voice treatment and swallowing treatment to be a broader, more all-encompassing kind of treatment, and that patients who complain of swallowing problems may not necessarily always have like a clear deficit in this one area, but we have to look at the whole system to figure out the problem from a functional perspective. So let's talk about how we treat these functional disorders. This is one of my favorite pictures, and it gives me great pleasure to share it with you. This is actually from a singing textbook. And I'll have you look at the bottom of the page and the complexities and interrelationships of the muscles of the head and neck make it difficult to readily assess definitive muscle action in speech and singing. However, it can be clearly shown here that the changes in position of the larynx, pharynx, and tongue inevitably affect the shape of the vocal tract. This is going to be critical when trying to treat a functional swallowing disorder because we want to know where the impairment is along this tract because it's the same tract. And then we are going to want to come up with some tools to fix whatever that is. So, first, let's talk about voice, and then we're going to talk about swallowing in terms of treatment. So, if we have a healthy, normal looking larynx, a patient comes into clinic, they say they've been hoarse. We look at with a video stroboscopy. Their larynx really is pretty unremarkable. We have normal vocal fold movement, nearly complete closure, symmetric vibration, but their voice is dysphonic. Where do they end up? In our office as speech pathologists. And they are often diagnosed with muscle tension dysphonia, which is a disorder of muscular antagonism affecting speech and or singing, leading to a laryngeal posturing abnormality. So the posture of the larynx becomes abnormal, affecting how the vocal folds close and vibrate. As we saw in that other slide with the yellow stars, we have a lot of muscles that close the larynx and only one that open. So if the larynx isn't coordinated for voicing, it doesn't necessarily allow the vocal cords to close. And that can lead to certain qualities in the voice, which I will discuss in a minute. Muscle tension dysphonia can occur in a primary fashion, meaning in the absence of pathology, and that pathology could be organic, like vocal fold nodules, or it could be neurological, like vocal fold paralysis. Then we also have a secondary muscle tension. So in compensation for or in response to a pathology like vocal fold nodules or vocal fold paralysis. And it can also be the cause of mucosal lesions as well. So it's kind of a complicated ball of wax. And I would like to give a huge credit to my mentor, Dr. Anat Kedar, PhD, CCC-SLP, who really taught me everything I need to know about MTD. So this is straight from her, and so the qualities that we tend to hear with MTD when we're listening to a voice is a breathy voice quality, like a fuzziness in the sound airflow on onsets, tendency or complaint from the patient that they're running out of air. They never feel like they have enough air to support their voice. They may even complain of getting out of breath when they talk. They feel like they're drowning or suffocating. And here's the key piece that we're going to focus on today: discomfort and tightness and pain in the thyrohyoid region. But it doesn't necessarily always mean it's on both sides equally, and vocal fatigue and loss of endurance. So, this is a great paper if you want to get familiar with MTD. We have many factors that can influence MTD. That includes psychological factors, vocal misuse and abuse. And for treatment options, we do things like vocal hygiene, but also voice therapy, circumlaryngeal massage, and manual therapy. Sometimes medical therapy is involved, but very rarely. So the thing about MTD is if there is an issue with the vocal folds themselves, if there is pathology and the surgeon needs to remove that, if you do not do therapy, the MTD remains. The motor plan for how to use the throat stays the same despite the pathology being removed. And this is why it's an important role that we play in remedying voice problems, because the surgeon can't fix the MTD. So the lesion is removed, but then there may be a lot of other things that need to be addressed. So if we were looking on stroboscopy, we would see these possible configurations above. These are not exclusive. There are many other configurations of the glottis that we will see on a strobe, but these are the most common. The wedgie is a posterior glottal chink, and this has been described, this is 40, 50 years ago. Morrison and Ramage were, publishing on this. And then the slit is an anterior posterior longitudinal gap between the vocal folds. And so we have this antagonism, which we will talk about in a future slide, where the vocal folds are trying to close to voice, but they can't fully close to voice. So this incomplete glottic closure leads to a response to try to push harder. And when you try to push harder, guess where the larynx goes? It goes up and forward. Why does it go up and forward? It goes up and forward because we have more muscles that lift than lower the larynx. 7 muscles that lift, plus a few more in the posterior sling. And then we also have the only 3 that lower. So we only have 3 infrahyoids. And so when the voice isn't working, the suprahyoid muscles start to take over. And that up and forward movement widens the gap between the vocal folds. And so additional muscles like accessory muscles, so sternocleidomastoids, scalenes, upper traps even, the chest wall, things start to engage that don't need to be involved in voicing. And so we have this over-valving or overworking to try to get the vocal cords vibrating as they should, but they're not closed, and so it sounds muffled and not clear. Let's see what this looks like on strobe. Stick out your tongue for me. Good. And relax. So this is a singer with MTD. Then alternate between E and a sniff. E, 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 E. The vocal fold motion looks normal. So anterior is to the bottom of the screen, posterior to the top, left side is on the right side of your screen, and right side is on the left side of your screen. For those of you who don't look at strobes all day, base of tongue, epiglottis, posterior pharyngeal wall. I'd like to show you this whole thing because she really demonstrates the configurations very beautifully. So you can see that anterior commissure is closing intermittently. So it does close. The vocal folds are vibrating. Almost stopped. Just a little mucus. Sorry. Yes, sorry. This is a hazard of the job. And then go up a little bit. So vocal folds are not closing. So we have a longitudinal gap.
Yeah, keep going up.
Starting to get very breathy.
Vibrato. Oh, just because my machine doesn't like it. I like vibrato, but my machine doesn't like it. That's okay. Is this where it's starting to get a little funky? Yeah, probably. Okay, give me a. Do that again. Do a nice high soft E for me.
You also may notice that her arytenoid cartilages are pulling towards her laryngeal petiole. That again is a suprahyoid engagement. So we like that for swallowing, right? We want those two things to touch.
All right, give me a little thingy. Let me hear that
So
now.
she's going to do it. This is really what she complained about
Actually, 1 second.
when she came in.
Do that again. Yeah, one more time.
We're almost done. She's going to do a little bit of singing now.
More time. Go to high.
A little more successful here. Oh, but then she starts to what we call splint or keep those vocal folds apart.
Give me the thingy. Can I really breathe?
It's hard for
No.
the strobe to pick up the vibrato, so we're trying not to have vibrato.
So I'll say, happy birthday. Yeah.
Happy birthday. Always a good choice.
Happy birthday to you.
Sounds a little breathy, right?
To you. Happy birthday to you.
And you can see that her vocal folds are not closing all the way.
Okay, good news. It looks super awesome in there, okay? Super awesome. Beautiful vocal cord.
Okay, so she's relieved. The vocal folds were looking very healthy. Most singers want to know if there's any kind of pathology, and there wasn't, so that's really good. So we did some voice therapy. Okay, whoops. So what do we do to treat MTD? Because this is going to be really relevant to treating functional dysphagia, functional idiopathic dysphagia. So we work on vocal subsystem optimization. The four vocal subsystems, which I mentioned before: respiration, power for voicing, phonation is the sound source, the filter, and this is way back to source filter theory in your acoustics class, in your prereqs, is the resonating tract and the articulation. So we have all four things working together to make the voice. But when we talk about subsystem optimization, from a auditory perceptual standpoint, the sound of the voice may sound breathy, but the issue is not with the airflow or the breath support. I mean, it could be, but the most important thing is that it's a phonatory or laryngeal valving issue. So somebody could have poor breath support as well, but if they're not closing their vocal folds, taking a lower breath may not fix that. Taking a three-dimensional abdominal breath may not fix that. What may fix it is actually fixing the hyolaryngeal complex, the larynx, to allow the vocal folds to close. So what do we do to do that? So we do some manual techniques for the hyolaryngeal complex. I always ask the patient, we say, is it okay if I touch your voice box? I'm going to touch your voice box in your neck and feel what it feels like. So this is where I would say to speech pathologists, certainly get the training that you need, but don't be afraid to touch the larynx because it's going to give you a lot of information. And then you can check in with your patient frequently if you're palpating their throat and their neck. So I would call this kind of the 10-point inspection. And so this is what I would do for every functional patient. This is for voice and for swallowing. So I'm going to be doing a palpation assessment. And what we're going to be looking for is the thyrohyoid space or lack thereof, which we'll talk about in a little bit, lateral edges of the thyroid cartilage, hyoid greater horns, cricothyroid, lateral movement of the thyroid cartilage, lateral medial movement of the hyoid, SCMs, scalenes along the side, upper trapezius, and then the base of tongue and submental musculature, super, super important. I've also started to do digastric trigger point assessment, which can really give us good information about how the digastric muscle is functioning as well. So have the patient rate that in terms of level of tenderness and discomfort. So the struggle for MTD is that we have vocal folds that want to close, but a hyolaryngeal complex that wants to rise. And so all of these muscles may be working harder than they need to. And we have all of those laryngeal elevators, which I discussed earlier, mylohyoid, geniohyoid, anterior and posterior belly digastric, as well as the thyrohyoid. And the thyrohyoid is interesting because it's an infrahyoid muscle, but it lifts the larynx. And so the larynx being lifted is really what we're going to focus on in treatment. So we want to decrease the muscle tension and the pull of the laryngeal elevators upwards by allowing the laryngeal depressors to anchor the larynx downward. So finding a rebalancing of the hyolaryngeal complex, those long muscles and the submental muscles as well. So how do we do this? We open what we call the thyrohyoid space. And this space is one of the most commonly described areas of discomfort for patients. So the palpation of this area is going to give you a lot of information. The thyrohyoid space may be completely absent and closed, and our goal then is to open that space in the vertical space and to decouple the hyoid bone from the thyroid cartilage. So this being that's not, we're not going to get too deep into that today, but the goal is to separate those two structures, the middle and lower part of my hanging basket analogy earlier. So we want to have free and flexible movement of all of these muscles. So now the pharynx, as we talked about the closed pharynx for swallow and the open pharynx for voice, is that we really for voice want to separate the tongue from the larynx so that the tongue doesn't overwork and press down and tighten and lift the larynx when it shouldn't. So we really have to work on disassociating the tongue from the larynx. And this is really important in terms of muscle memory, because when patients have a need to communicate, they will communicate by any means necessary, and they may be gripping and holding with their tongue to force their voice out. And so we work on exercises to decouple those two mechanical operations. And so if we also are squeezing our constrictor muscles, if we are using our posterior sling and our larynx is also lifting, our larynx is going to be malpositioned for voicing. And so in this image here, you can see the tense constrictor, super important for swallowing. We want to see that pharyngeal stripping wave. We want to see that movement, that nice smooth movement of the bolus downward. But for voicing, we actually want the opposite. We want that space to be open and flexible so that the vocal folds can adduct posteriorly and close. So this is kind of manual labor, if you will. This is I show you, we look for the spot and I show them where it is and how to open it. So first starting with massage, sometimes I use reposturing and work with the patient on helping them find these anatomical landmarks for themselves in front of a mirror so that when I do the therapy on them, I can then teach them and they can find it on themselves. So with the goal of being able to open the thyrohyoid space and lower the larynx. So the base of the tongue is often codependent with the motor plan for voicing. So if we can disassociate the tongue at rest, that's going to give us opportunity to do that with voicing. So patients may not even realize that their tongue is tense until you palpate it. So we really want muscle specificity. And I would describe this in clinic as I don't want your 12th cranial nerve, running the show for your voice. So if every time a patient is voicing, they're gripping with the suprahyoids and submental musculature, they may be working a lot harder than they need to, and it may feel really bad. So, not to discount postural alignment, especially nowadays because we are so tied to our screens all the time. It's really important to pay attention to somebody's anterior to posterior position and also their alignment in terms of like their ears over shoulders over hips. Because the movement of the chin upward, if let's say you have bifocals, is going to elevate the larynx. So, now, how do we apply this, or how do we use what we know about voice and already what we know about swallowing to treat functional idiopathic dysphagia? Because they're the same muscles, but they have a different function. So rather than keeping them siloed, let's leverage what we already know to help us figure out how to treat functional idiopathic dysphagia. So, and why am I interested in this? I'm interested in this because I found that a lot of modified barium swallow studies are normal. And in fact, in 1 year at our academic medical center, 46% of all modifieds were normal. Now, I'm not implying that everybody in this 46% that were normal have functional idiopathic dysphagia. They could have other things going on. So I'm certainly not implying that. But a great majority of patients who go for a swallowing study with some kind of swallowing complaint are actually found to have a normal swallowing evaluation. So I think the question that I first had was, well, how many patients is this? Because I certainly find that there's a lot of patients who are seeking care for this. And, what can we do to treat them better? Because it is a very large cohort of patients. So if you have a functional or if you have a subjective complaint of dysphagia, but a normal exam like Susie, because she can't swallow, she's seen everyone. She's had the $1 million workup. EGD, barium swallow, and esophagram. She's had an upper GI. She's had trials of proton pump inhibitors, H2 blockers, manometry, everything. She's gone to ENT, flexible laryngoscopy, modified barium swallow, fees even in clinic, and a second trial of a proton pump inhibitor and or H2 blocker. But Susie still can't swallow, and she doesn't really know why. It just feels really bad. She's avoiding foods. She's embarrassed. She's coughing. She feels tightness. She doesn't like it. She's avoiding eating even. So when all of these things are normal, we may want to consider that the patient may have something called muscle tension dysphagia, which is a diagnosis of exclusion for functional idiopathic swallowing disorder, which is associated with abnormal laryngeal muscle tension, which is what we just talked about. And this abnormal laryngeal muscle tension, and I'm reading right from the academic paper by Christina Kong, abnormal laryngeal muscle tension is often associated with disorders of laryngeal hyperresponsiveness, such as muscle tension dysphonia, chronic cough, globus, and paradoxical vocal fold motion disorder, or ILO, as we often call it now. And MTDg patients may exhibit concurrent disorders of laryngeal hyperresponsiveness. So if a patient has a normal swallowing evaluation, but a subjective complaint that it's difficult to swallow, we may want to consider this. Now, this is an exclusionary diagnosis, which means that there are there's an established criteria that we have to have a minimum workup to be able to even consider this diagnosis, because we want to do this with care. We certainly don't want to be missing any issues which could be very, very serious. like esophageal cancers, etc. So this is what the AAO, American Academy of Otolaryngology, has described with a statement in 2023. You need a clinical swallow evaluation with a thorough history of the head and neck, with a thorough history, pardon me, and a head and neck evaluation, and a scope, so a laryngoscopic evaluation of the larynx and pharynx, and then an instrumental oropharyngeal swallowing evaluation, and an esophageal evaluation. So until these are conducted, we can't assume that it's MTDg. Now, we also know that issues in the esophagus can have a great impact on the throat. And so there can be multiple phase issues and interrelated phase issues, and that something in the distal esophagus may refer all the way to the throat. So there may be compensations also motorically that can have a downstream effect on swallowing. So muscle tension dysphagia actually has now, over the past 10 years or 8 years, 8 to 10 years, quite a bit of evidence now. So we have a bunch of studies to look at, and they are right here. So we're going to look through these. We talked about Christina Kong's article, which I just discussed. And then we have a few newer ones. I'd like to bring your attention to the 2024 citation of the role of laryngeal hypersensitivity in dysphagia. This is a scoping review. This is a phenomenal article which will give you a great overview of the issues in dealing with dysphagia and hypersensitivity. So this is a good place to start. I think if you are new to this and wanting to learn more, I think it'll give you a really good summary. It's extremely thorough. So also for us, we live in this world where we're assessing the oropharyngeal swallow all day, but for the GI perspective, we're kind of the caboose at the end of the train here in terms of their algorithm. So we may not always be the first stop for them. So how do we treat MTDg if it comes our way? What do we do? Because treating this is very similar to voice because it's the same muscles with a different function. So we have SLP treatment for both primary and secondary MTDg. So a patient may have a primary MTG, no pathology, no findings, or they could have, just like muscle tension dysphonia, have a secondary muscle tension dysphagia in relation to some other issue that they may be having with their swallowing. So we again want to unload muscle tension with various techniques which are similar to those that we use for muscle tension dysphonia. And then these acronyms, if you're not familiar, these are voice treatment techniques, Lessec-Matson resonant voice therapy, semi-occluded vocal tract exercises, conversational training therapy, and again, manual therapy with both circumlaryngeal massage and reposturing and what I would describe as the Walt Fritz techniques. So again, we may want to broaden our conceptual framework to include the idea that swallowing can be dysfunctional in many ways than just a weak swallow. And indeed, many swallows may be hyperfunctional. And to that point, doing strengthening exercises would be contraindicated in this population. And this is really, really important because if you're working with somebody who has an extremely tight throat, has very rigid hyolaryngeal complex, it is not free, it is not flexible, and you're giving them strengthening, they may plateau or get worse. So I think we need to be really definitive in how we're looking at this and also really look at the whole tract and the whole person. So it may be that you need to palpate them if they, to consider this. So that we shouldn't just give every patient strengthening exercises. We should really look at what exactly they're doing with their throat. So again, we need to assess the thyrohyoid muscle and the thyrohyoid space and the paralaryngeal muscular tension and rigidity. And so The thyroid muscle is super critical for swallowing as well because it may be already engaged and tight before the patient swallows. So, if the hyolaryngeal complex is elevated and rigid prior to the act of swallowing, it is malpositioned, and then the patient may describe that it feels anchored or they can't initiate the swallow. And we would assess this through the same kind of 10-point inspection that I would do for muscle tension dysphonia and have them rate this. And if they come to your office, you want to look at how everything is at rest, and then you can work on that at rest. So if they have less flexibility and range of motion, you can restore that and see how it affects their swallowing. So I did this with a cohort of patients, and I gave them basically this exact protocol. And this is development from Joseph Lieberman, a British osteopath. And they would implement this swallow therapy, which is basically physical therapy for the throat. And they would do it 3 to 5 times a day for 3 to 5 minutes. And pardon me, they would actually get better. And this was really interesting to me because when I was first practicing, I was kind of like, wow, this is great. Like we're actually helping people with this. And the universal complaint would be difficulty swallowing solids, a feeling of anchoring for the onset of the swallow. They couldn't quite get the swallow started. And so this is a paper, it is currently unpublished, hopefully will be published. But this anchoring feeling at the start of the swallow is because the hyolaryngeal complex already elevated. So it doesn't really have anywhere to go. So when they go to trigger the swallow, they can't they can't lift their larynx moving up and forward to lift the hyolaryngeal complex. So that's the thing that we need to change. And so through this, they are also increasing their self-efficacy because they're doing it on themselves. So let's talk about my patient, MZA. He came from an outside hospital, from a GI provider. He's a 29-year-old male and an elementary school gym teacher. He was referred by his GI provider. Reflex workup was negative. He's had a symptom duration of dysphagia for 1 year. He complains of solid dysphagia. He can eat mashed potatoes, soft foods, no problems with liquids. He can't have meat, so it'll get stuck. He feels like he kind of has to like hack it back up, and then he feels like it's right there where it gets stuck. And the MBS at the hospital showed a mild moderate oral phase deficit with triggering a swallow reflex with solids. Intermittently, the patient was unsuccessful in swallowing solids on the first attempt and unable to trigger swallow reflex intermittently with solids. So he saw an ENT, he had reflex treatment. He did have enlarged tonsils, but not large enough to merit removal. And he had no family history of neurological problems. Occasional like pain with swallowing, but nothing major with that. He had a wrestling injury and he had to have his nose fixed. I think he probably had a septoplasty and or rhinoplasty, but that's how he described it. So his voice, he's a high school gym teacher. He uses his voice a lot. And he has mild roughness, breathiness, and strain, and he has a lot of glottal fry. So on his flexible video stroboscopy, we saw a mild to moderate anterior to posterior compression during phonation. Now, when we think about swallowing, we think of arytenoid cartilages to the laryngeal petiole. We want that airway protection. But for this patient, he's doing this when he's talking, and he's staying in this position all day because he talks a lot. So he's voicing and he's already compressing his throat. And so here's the kind of rating. This is what a rating would look like if I were having a patient rate their tenderness and discomfort throughout the hyolaryngeal complex. And he had, interestingly, no tenderness in the thyrohyoid space, which is extremely common, but he had a elevated vertical height and he had a lot of tenderness bilaterally in the suprahyoids. And you couldn't move his hyoid. Like you couldn't, you can try doing this on yourself right now. You want to be able to move it back and forth. You couldn't move it. You couldn't move his thyroid cartilage. And then he had some CT discomfort as well. Um, so he had a couple of uh, accessory muscles that were also tender, and then some mild to moderate rigidity of the base of the tongue. No issues with the jaw. So what do? We did this kind of, I wouldn't say protocol because every patient is different, but using this framework for teaching patients how to do manual therapy on themselves. So we did stretching and reposturing. This is something that I would do on the patient. So anterior stretch of the hyoid bone to allow for symmetry within the larynx. Because if you have a hyoid that's pulled posteriorly to the cervical spine and the patient goes to swallow, maybe they say, oh, I feel like a weird click, or I feel like something sticks there. And then also oppositional stretch of the thyroid cartilage and the hyoid bone in both directions, again, to find that balance of the hanging baskets that we talked about earlier in both the vertical space and the anterior to posterior space. So really thinking of how the structures are interrelated as they are biomechanically working. And then opening the thyrohyoid space and finding that neutral position of the larynx, which often is down because we have more muscles that lift than lower. The larynx is just going to go up. So he would do this throughout the day, lateral rocking of the thyroid cartilage and the hyoid bone. And we did tongue extension exercises so that if he had tension here and he was already starting with that swallow initiation, with that contact of the tongue tip to the alveolar ridge, he's already tight, so he couldn't really initiate that swallow. So we freed everything up so it was a little looser, and then he was able to have some graham crackers at his session with cranberry juice, and he felt like it went down with no sticking. So. Oops. So after 6 weeks, he reports that he was like 60% normal. He continued to use his massage program. And I think the most important thing was that he could identify when his throat was becoming tight. And so he was able to immediately do something to not allow that to progress. And he also correlated that tightness with when he was feeling stressed and anxious. So, and he could localize the tightness to that thyrohyoid space. And for him, he is a gym teacher, so he also lifts weights. And he has a high voice demand. He teaches the gym class at the high school, but he also is the football coach and the wrestling coach. So we worked on vocal hygiene and ways that he can use amplification to improve his vocal hygiene so he's not yelling and screaming so much, breathing strategies for weightlifting. And then we also did a few exercises like straw phonation. And then we also worked on that breathing coordination because he was pulling up into his chest for every breath. So really treating the whole system, even though his main complaint was his swallowing. So that's all I have for my lecture. These are my references. And a big thank you to all of you for your time on this beautiful late spring evening.
Awesome. Thank you so much, Michelle. We do have several questions, so we'll go ahead and dive in. One attendee wrote in and said, I'm wondering now if someone I saw recently for fees, status post, CVA, and a very breathy voice had MTD and not just edema. Can flexible distal chip scopes catch MTD?
Oh, yeah, for sure. I think you always want to have a strobe to really know for sure. Certainly with a CVA, we would want to know, about the vocal fold motion. Is the vocal fold motion impaired? Um, Yes, so distal chip scopes could give you some insight, but I think you would want to follow up with a video stroboscopy to be sure. But you may see some of those signs. So glottic insufficiency isn't necessarily exclusive to MTD. There's so many pathologies that can lead to it. So nodules can cause glottic insufficiency, paralysis. So I think you'd want to have a little bit more information with a strobe, but I think it's possible.
This person wrote in and said, do you have any recommendations for courses about manual therapy?
Sure. Yeah. There are some newer courses coming out. So I have done the Walt Fritz course, but I would say that the the techniques that I referenced in this are things that I actually learned in school during my training. And then I read a lot of articles in addition to that, and I think manual therapy was always part of my practice from my training onwards, so I'm super grateful for that. I hope that we continue to expand our skill set in this area. I think there are some cross-discipline treatments that we do. I work with a wonderful PT who we often send patients to for cervicalgia. So I will say that I know that there's a couple in New York that were recently um, held this past year. So I guess I'm a little spoiled in the sense that I was lucky that I got to learn these kind of from the start. Stay tuned for hopefully some more options for that. Um, so yes, I mean that's something that it'd be great to have more offerings with that. So I don't know that I answered your question very well, but I think whenever you can get the opportunity, even observing practicing clinicians, I think just spending some time in a clinic is like even just a couple of hours would be great too.
This person wrote in and said, can you talk more about how to rate tenderness or learn how to rate tenderness?
So yeah, so how do you ask the patient to rate a level of tenderness? Certainly all of the things that we're talking about here are very subjective to the patient. And I think that points to kind of the subjective nature of having a functional swallowing disorder. We see on an instrumental that it's normal, but for the patient, having the each muscle identified, and certainly when you're palpating, you're not just palpating, always one muscle, right? Like here we're palpating the strap muscles and we're palpating the platysma. So when I have a patient and I palpate here, I do some probably small circles and I say, can you rate your level of tenderness on a scale from 0 being nothing to 5 being the worst tenderness you could imagine? I also don't let them do like halves or quarters, so whole numbers only. And so think of it as a Likert scale, like mild, mild to moderate, moderate, moderate to severe, and severe. So 0 is nothing at all, 5 is the worst. You might find that if you touch somebody's throat, they're going to have like a level 5. So that is their perception of the tension in their throat. Typically, that does correlate with what you feel. And the only way to get better at doing this is to really do it. So that feeling of kind of going through all of these areas, and it may be completely unremarkable. And so that's how I would note it. The patient has it's up to them what they think 0 to 5 means to them. But I would say it typically correlates with what I feel from a rigidity perspective. I have them rate the tenderness and I perceive like how rigid the muscle is and note that.
This attendee wrote in and said, are there telltale signs that you see on NBS that would raise red flags for MTD?
Yeah, that's actually my next research question. So I will get back to you on that. There is a follow-up study in the works for the cohort study I just shared with you. And that's what we're actually looking for. So I might have an answer to that question. Um, you know, Certainly I see all kinds of interesting things in instrumentals, but I wouldn't want to specifically say that just kind of anecdotally. I think we're going to look and answer that question because I think it's an important one to look for, to know what to look for. And we may do that with measurements. So stay tuned. We'll have that coming in hot in a few years.
Amazing. I still remember the first person to mention that to me was actually Walt, who you mentioned, because I asked him, I don't specialize in voice, but I had all these patients I was seeing for outpatient NBS, and their studies were normal, but they still had complaints. So such
Yeah.
an awesome topic. I'm so glad to hear that you're doing research on it.
Yeah, I mean, that's the goal. That's what we want to do and give patients more resources and clinicians more resources.
This attendee wrote in and said, is quote unquote scissoring of the arytenoids during phonation on laryngoscopy a symptom of hyperfunction?
Ooh, scissoring. Scissoring, usually we would see like a prolapsing of the arytenoid. Sometimes we would actually see that in weakness when one arytenoid passes by the other. Typically, you would see supraglottic hyperfunction is one of the things. So you would see the like we saw anterior to posterior supraglottic hyperfunction, and then the lateral medial almost looks like there's like a second squeeze. There's the vocal cords, and then they're being obscured by the area that the false vocal folds above there. But scissoring is usually seen when you have a more flaccid arytenoid complex on one side, and then a normally innervated one on the other. That's what I would say. Typically see scissoring, and certainly if somebody wants to talk about that more, I'm open to that. But that's typically when I see scissoring.
This attendee wrote in and said, I had a patient with similar symptoms, but his diagnosis was an esophageal stricture.
Yes.
You mentioned the esophagus. Can you explain why would esophageal issues result in a breathy voice? And would the recommendation, i.e. massage, still be helpful if the known issue is lower?
Yeah, so this is a case of probably possibly, I haven't, seen this patient, but a secondary muscle tension dysphagia. I think this may come from, I think, a natural instinctive response with an anticipatory problem with the swallow, right? If you have stricture, you're not going to get clear passage of the bolus through the esophagus. The patient's going to anticipate that and possibly try to compensate for that. And so that's what we mean by interrated phase issues. I don't think it's a waste of time to determine if they do have another issue. I think it would also be reasonable while they're being cared for and treated for their esophageal stricture to follow them and find out if their symptoms resolve. So you can kind of be, on the back burner and say, hey, like if you get this treated and you're still having issues, let's address them. Let's address the primary issue. In the correlate in voice would be let's address the nodules, let's address the paralysis, and that will help us, determine what we need to work on. So I think it's possible, but you may want to take a back seat until the stricture is treated.
This is a really great question as well. How do you differentiate functional dysphagia versus muscle tension dysphagia?
So, yeah, so functional, I think we put that in a big, large bucket in terms of uh, there can be, there may be certain hyperresponsiveness or hypersensitivities of the larynx, which could lead to issues with swallowing, but the patient may not have physical palpable tension. So I think you have to address, like, here's this umbrella of functional being not or like a non-organic or, non-neurologic cause. But we can also have functional dysphagia where, they don't have a muscular problem. It's more that they're afraid to eat. And I work with those patients too. So if we're thinking about that those patients have a functional disorder, But they also have like self-restriction of diet for really, you know, something that may have some kind of history that's complicated that may not actually even be muscle tension related at all. So I think functional dysphagia is a broader term. And then we would like to palpate them to know, like, hey, is this muscle tension? Is there actual tension here? And that's how I would differentiate it. I would say some of my patients with phagophobia or fear of swallowing also do have muscle tension, but I think those are separate issues. So the functional is the big umbrella, and then underneath that are other things that could be, defined further.
Awesome. We're right at 9 o'clock, so I'll ask you one more and then
Sure.
we can wrap up. This person wrote in and said, if you are suspecting tension dysphagia after your clinical examination, would fees be preferred to an MBS?
Oh, I think both are reasonable. I think sometimes we have to do both. I don't think there's one right answer to that question. We certainly need to meet those four requirements, that we discussed earlier as outlined by the AAO position statement in 2023. Um, if you have the ability to do a fees and you've given you've done a clinical swallow and you're like, well, I can do a fees, then do a fees. If you feel like on the fees, you don't get enough information, or maybe you notice when you're actually doing, the evaluation that it turns out there's some serious retrograde flow coming from the esophagus, like that could drive your decision making. But I think if you can offer a fees, I think it's a very reasonable place to start. And I think your question may allude to like, is one test better than the other for assessing muscle tension dysphagia? And I think the answer is probably no. But I think it's probably an individual patient and, patient selection and test selection issue. So if you have the ability, I would do it.
Well, I know we didn't get to all of the questions in the chat. There were quite a few, but just out of respect for everyone's time, we'll go ahead and wrap up. So, housekeeping items. If you would like ASHA CEUs for attending this evening, I put the survey link in the chat again, and it'll also be sent out via email twice. And then the replay will be up on the website probably tonight, but at the latest within 48 hours. And then if you'd like a certificate of completion, just send us an email at tims-unum@tims.com with your first and last name. And Michelle's email is up on the slides because, like I said, I know we didn't get to all of the questions. This was such a great presentation, Michelle. Thank you so much for offering your expertise, and I want to thank everyone for joining us tonight.
Thank you so much, Brooke. It was a pleasure to share time with you today. Thank you so much for listening.
Bye, everybody. Have a good night.